What if one conversation could change the course of someone's life? Imagine sitting in a room with your loved one, you're waiting for answers, and then you hear the diagnosis of dementia for the first time. What do you say next? What should you say next? And how do you prepare for a moment that feels impossible to prepare for? Well, in today's episode, we're pulling back the curtain on one of the most emotionally charged and critically important moments in healthcare, delivering a diagnosis of dementia. Whether you're a caregiver, a clinician, or someone living with memory changes, this conversation with Dr. Melissa Armstrong is one that you're not going to want to miss. Welcome back to all of my YouTube subscribers and especially my AgeWiseU members. If you're new to this channel and the podcast, welcome to This is Getting Old, Moving Towards an Age-Friendly World. I'm Dr. Melissa Batchelor, and I'm a nurse and a nurse practitioner with nearly 30 years of experience caring for older adults and their families. We've built an amazing community over the past 5 years of the podcast. So if you like the podcast, please go to MelissaBPhD.com to grab your free podcast insider guide. It has 2 essential checklists that have been designed to help you to be proactive in aging well, but also to help you better recognize the warning signs that might mean a person is experiencing memory loss. Then all you have to do is watch your inbox for information on how you can join me for future exclusive events and connect with our community. And I'm joined today by the amazing Dr. Melissa Armstrong to talk about getting a diagnosis of dementia and how clinicians, families, and patients can navigate the before, during, and after sides of this conversation. And we're going to explore how empathy, timing, and communication can make all the difference. So welcome, Dr. Armstrong. And before we get started, maybe you can introduce yourself.
Thank you so much for having me. I am Melissa Armstrong. I am a neurologist, and I am the B.J. and Eve Wilder Professor in Alzheimer's Disease at the University of Florida, and also the director of the UF Dorothy Mangurian Clinical Research Headquarters for Lewy body dementia. In addition to evaluating people living with movement disorders and memory problems, I also do research, and my research focuses on the lived experience of disease for people living with these diagnoses and their families and caregivers.
Right, so that's amazing. Great work that you're doing. And actually, it's through your research that we got connected. You had published an article that a colleague of mine saw and said, hey, this would be a great topic for a conversation or for a podcast. And I have to agree. So before we get too far deep in the woods, let's just remind people kind of what this term dementia actually means and why it's important for people to understand that diagnosis compared to what maybe happens with normal aging.
Yeah, it's a really great question. And it's a question I hear a lot in my clinic. People say, is this dementia or is this Alzheimer's? And the answer is dementia is really just the medical word that says a person has had a change in their memory and thinking. And that change is substantial enough that it's really affecting their day-to-day life. And then there are a variety of different things that can cause dementia. Alzheimer's disease is the most common, but these kinds of changes can also happen due to other diseases and stroke and for other reasons. So dementia is really just an umbrella term for a bunch of different diseases that can affect memory and thinking. And it is different from normal aging. It's not too uncommon to have to think of a word you want to say or put your keys in the wrong place sometimes. But as we get older, there's also an increasing risk of having memory and thinking problems due to a disease. And so if the problem is consistent or increasing and growing over time or affecting day-to-day life, those are really good times to get checked out and say, well, maybe this isn't just getting older.
All right. And so then my next question is, a lot of times when we hear the terms, dementia or Alzheimer's, there's a lot of stigma associated with it. It's the number one most feared disease above heart disease, cancer. It's the number one thing that people fear. But how do you see that role play, like the role of fear and people kind of addressing a memory issue?
Yeah, it's really important. So there's even discussion about should we keep using the term dementia, because there is a lot of stigma associated with that term. And there's a group right now working on, okay, is this still the right word to use, or should we be calling it something else? I think it is important to know and to see a doctor when there is a disease involved, because while we don't have a lot of great treatments for these diseases, there are some new treatments that are FDA approved for people with the early stages of Alzheimer's disease. And across these conditions, you can get involved in research to try to improve quality of life or find new treatments. And so there are a lot of good reasons to get an answer when you're having a problem, even if it's not always an answer we want. But I think we do have to think, okay, well, it's important to have this answer, but there are different ways I could tell people about it. Or how do I handle it? So I wouldn't want stigma to make people not get a diagnosis that can be really valuable. But I think it's really important that we think about that aspect of it because it's very real, and also think about, well, how should we address that as a society?
Right. And then I was just interested in like, what else would we call it?
I
Yeah.
mean, it's a valid question. I mean, there are even other terms now. So, there's something called major neurocognitive disorder, which
Oh,
is
yeah.
dementia, and minor neurocognitive disorder, which is akin to the term mild cognitive impairment. I do think that's a challenge. So, if we've got to call it something,
It needs to be simple.
there are also approaches to saying, okay, well, we use the word now, but how we use it matters. So, for example, in the past, sometimes said this is a demented individual, but that phrase is kind of stigmatizing. So
Mhm.
now we say, well, let's not approach it that way. Let's say this is a person with memory problems, or even a person with dementia, or a person with changes in memory and thinking. And then we're really emphasizing, hey, you're a person with something. You're a lot more than that with. You're a husband, a wife, a mom, a dad, a carpenter, you're all sorts of things with dementia. So there are even some ways we can keep using the term, but in a better way than it may have been used in the past.
Right. So I typically say, an older adult living with
Yeah,
dementia or Alzheimer's.
the perfect way to say it.
So, all right. So now we're going to talk a little bit about, kind of the before, like before you get a diagnosis. And, you mentioned, people getting in to be evaluated. That's actually really critical because there could be something else wrong that's fixable. I've often said, well, I mean, that dementia is a diagnosis of exclusion, which means you have to rule everything else out. So it is important for people to seek answers. So let's talk about why it's so important to kind of put the person who may be diagnosed and to include them in these conversations? And how do you recommend that we bring people into this conversation?
Well, I think it's really important that we remember that even when someone is having trouble with memory and thinking, that doesn't automatically mean that they can't participate in these evaluations or conversations, especially now as we get better at recognizing it earlier in someone's life. People are diagnosed with mild cognitive impairment when their memory and thinking aren't as good as it used to be, but they're still largely independent. In mild dementia stages, people may need some support to participate in conversations and decisions, but they can still be involved in decisions. So I think it's really important that we don't disenfranchise people living with memory and thinking diseases just because we've put some label on them. At the same time, to understand it well or participate in a conversation or make a big decision, they may need more help than they've needed in the past. And that is often family members or close friends. And so when doing these evaluations or having these conversations, it's important to identify who should be the people in the room. You might identify those people in part by asking the person living with memory and thinking problems, who do you want to be here? But then another way to think of it is, okay, if this person can't make decisions and needs a lot more help, who is going to be the person providing that help? And that person is good to involve from those very earliest stages.
Right. And so, what do you think is the best way to involve family members without kind of overwhelming or excluding the person who's at the center of the discussion?
It's a great question. And I think it also goes both directions. So I've heard from people who said, look, my doctor talked just to my wife or, husband, they didn't ask me anything and they felt very offended by that. And I've also talked to caregivers who said the doctor only talked to the person with the disease, but I'm the one who sees what's going on. And so I think the answer is we need to talk to everybody. And so my own approach is usually I start by talking to the person living with the disease. Even if they're at a stage where they can't tell me a lot, I want them to know that I prioritize them. So I start an evaluation asking what they want to let me know or what they want to tell me. And after they've had that opportunity, then I move to the main caregiver. And then I give them the opportunity to fill in the blanks or give me extra information. And then sometimes there are more family in the room, and then I'll move on, to the next person. And I like giving everyone in the room the opportunity to speak.
Yeah, I mean, because they wouldn't be there if they weren't invested, in the conversation. Or someone might be like, I'm just driving today.
Well, that does happen. And
Yeah.
sometimes, um, people will, I'll even say to the person living with the disease, I'm really glad I heard from you. But, with these diseases, it's important for me to hear an outsider's view too. So I really want to know what you're experiencing. But I also want people to know, I want to know rather what other people see. What does the observer have to say? And that hopefully gives the family members a little bit more freedom to speak because I've made it clear that I really do value the experiences of the person living with dementia, but I also need to know what other people are seeing.
Right. So speaking of that, we're at the point now where we haven't gotten a diagnosis. So why is it important for people to share their observations? How do those play into your decision making or into or what are the types of information that families should be concerned enough about to go with the doctor to tell the physician?
Sure. So, one important thing with dementia or memory and thinking problems is there's a lot of diversity in what people experience. And that can be due to different diseases affect memory and thinking in different ways. But along with that, people living with memory and thinking problems will have different levels of recognition of there being a problem. So sometimes the person with memory and thinking changes recognizes that something is wrong, that they're having challenges, that things aren't the way they used to be, and they are themselves partially invested in getting an answer. At other times, the person with memory and thinking problems has absolutely no idea that there's a problem. And if you ask them, they will say everything is fine, there's no concern at all. In both cases, it is really helpful to have that outside observer, what they see. For the person who doesn't recognize that there's a problem, we're going to rely almost completely on the family or observer to say, what do they see, has been changing, what's wrong. But even when someone has some insight into the changes they're experiencing, it can be useful to have that outside observer weigh in about changes they've seen as well. And, that just reinforces the need when we're having these kinds of conversations, we really want to have them with the person experiencing the problem, but at least one informant or family member or caregiver who can add that extra information.
Yeah. So well, I was thinking, I got a question from social media from one of my listeners, and she was saying that her mom had no insight into any of the issues. And I think that families can see that as denial, like they're just denying there's a problem. They're not willing to accept that there's a problem. But I think it's important for people to understand that it's truly sometimes just a lack of insight. Like a person with dementia is doing the best that they can. I mean, they're typically not like trying to manipulate the situation or anything like that. So I think it's important for people to know that it's just a lack of insight versus other people have that. Is there any distinction with the different types of dementia as to like I don't think it's more like, people with Alzheimer's lack insight, frontal lobe has it, are there any distinctions?
It can be different in different dementias, but there's a lot of variability even within certain dementia diagnoses. And so it would be hard to generalize to everyone with a certain diagnosis. But I really do want to reinforce one of the things you said. I mean, there are people who have denial. That can happen. But not recognizing there's a problem can also be a brain change that is part of the disease. So it's not even that a lot of these people are recognizing it and denying it. It's that as part of the brain disease, they really do not see that there is a problem at all. And I think that's one of the times where it's most frustrating for families, because you really you can't reason, you can't talk about it. It's hard even in the doctor's office because you're seeing all these problems and the person's like, no, I don't have any problems at all.
Yeah.
And then it's also hard to say, oh, well, I need a caregiver help to come in. And the person with disease is like, why? So I think that is really one of the most challenging circumstances in dementia, but it really often is from the disease itself rather than a willful denial of a problem.
Right. But I think that's also, caregivers can internalize that and become really frustrated to be like, I can't believe that you don't see this. And so just understanding that they truly can't see it helps you as a caregiver kind of reframe to be like, okay, this is what we're dealing with. This is part of the disease. And then the other thing that you said was the variability. I think that's one of the most difficult things about getting to a diagnosis is that if you've seen one person with dementia, you've seen one person
That's right.
with dementia, um, which makes it hard, go ahead.
Oh, I just wanted to add one more thing on that lack of recognition. Part of that can be lack of recognition of the memory and thinking problem, but there are also other symptoms where that comes in. So in Lewy body dementia, people can have visual hallucinations when they see things that aren't really there, but they can also have delusions where they believe things that aren't really true. So they believe their spouse is having an affair, or they think there is an intruder in the house. With both visual hallucinations and delusions, it can be very similar. The person experiencing those things can be totally and completely convinced they are real. And this is because of the changes in the brain, and nothing you can say or do will convince them otherwise. It really doesn't help to try to rationalize or explain or work someone through why it's not really true. Their brain won't let them grasp that. And so in those circumstances, it doesn't actually do the person living with the disease or the caregiver any good to keep circling and arguing and arguing. And so in those cases, we recommend really practical strategies. So rather than trying to convince someone there's a problem or trying to convince someone that that thing really isn't true, it's better to just kind of go with the flow and distract them and get them onto a new topic or get them interested in something else. It's really a matter of playing along with it, though you can go with the flow, but it's not engaging because engaging just doesn't help.
Right. I had a friend of mine call me. She said that her mom was seeing little kids, like she was looking out the kitchen window and she was seeing children playing around this barn out in their backyard. And it wasn't distressful because I think that's the other thing. Like if the delusions or the hallucinations are distressing to the person, definitely distraction is going to be where you need to go with interacting. But I was like, but if she's not upset, like you might want to go make sure she doesn't have bladder infection or make sure there's nothing else going on. But if she's not distressed by it, I'd ask questions. Be like, well, what are the little kids doing? What game are they playing? Like, what are they wearing? Like to learn more about what they're seeing. But then you're kind of, and Maria Shriver actually has an Instagram video where she was talking about her dad hearing water running. And she started to say, she's like, no, Dad, that's traffic. And he's like, no, it's water. And in that moment, she was like, I'm just not gonna argue. I'm just gonna sit here and be like, that water is lovely. And then they had a meaningful moment rather than arguing over whether it was traffic or water that he was hearing.
Yeah, we do everything we can to decrease, arguments or disagreements. The more we can do to make it good for everyone. Better for the person living with the disease not to be confronted that, you're wrong, but also better for the caregiver because it doesn't really it's not soothing or helpful for them either.
Yeah. So the two things I'll usually tell people is like resistance is usually met with resistance, and it takes two to tango and two to tangle. So, all right. So now let's move into like when you're getting a diagnosis or the diagnosis is being delivered. How do you think, what are your recommendations for how clinicians can approach that, delivering that news with empathy, but also clarity?
Yeah, so I think, you said one of the key words and one of the things we talk about in the research that you mentioned earlier in the program, that it really is important that clinicians give these diagnoses with empathy. I've definitely heard hard stories from people who have gotten these diagnoses in a way that made it even worse. I mean, let's be honest, no one ever wants a diagnosis of dementia, but definitely how you hear that news is going to have some impact on your initial reaction to it. And
Mhm.
so, in the ideal world, you want a good environment. It should be, a quiet place where you can really have this conversation. There should ideally be enough time, though there are certainly challenges with that in our health environment. You want the key people in the room, which means the person with the disease, but also their main support system. And then it can be a doctor giving the diagnosis, but there are also other medical professionals that can give these diagnoses. There are different strategies that medical professionals might use when giving the discussion. So when we did interviews with people who received the diagnosis of dementia, some of them really like to hear, okay, what are the steps that led you to this conclusion? Other people don't really care about the steps. They just want to know what the answer is. Most people want to know the specific problem that they're having. A very small number of people, and this is from various research studies, would rather you keep it vague, like memory problems. But most of the time, giving a specific diagnosis, you have this disease, is really valuable. And you want that specific answer rather than memory problems or even just dementia. Because getting that specific diagnosis is going to send you on different routes. Having a specific diagnosis will let you know, okay, well, these symptoms go along with this diagnosis. And these things can be explained by this diagnosis. But this other thing I have doesn't match. So maybe I need to see my primary care to discuss that again. Getting a specific diagnosis can let you know, well, what to expect, because different dementias have different paths. It can also get you connected to an advocacy organization. So the Alzheimer's Association helps people with most kinds of dementia, even though its name is the Alzheimer's Association. But some of the less common dementias also have specific advocacy organizations like the Lewy Body Dementia Association or AFTD for frontotemporal dementia. And getting linked to those specifically can be really helpful because then you're linked to other people who really know what you are going through. And then getting a specific diagnosis can tell you, am I eligible for certain treatments or am I eligible for certain research? And so I think whenever possible, getting that specific name can be really helpful.
Yeah, but we also hear about the number of people that are misdiagnosed,
Well, that's
up to
true.
like 80%. So it's, you know, in that situation, I guess it's like sometimes you're given news and it resonates and you're like, okay, we definitely think this is what it was, versus being given a diagnosis and you're like, I don't know.
Yeah.
Like,
So I think so that definitely happens. And I think that's good. I mean, hopefully people will see a clinician, a doctor, or other medical provider who has humility and reassesses a diagnosis. So especially in people where it's not perfectly clear, I'll often say, this is what I think today, but next time we're going to reassess it and see, is this still the best match? And then the next time after that, we're going to reassess it again. And sometimes you have to do that even with dementia in general. There are times where we say, look, we're not exactly sure what the cause is, but one of our biggest clues is what changes over time
Right.
that might send us in a certain direction. So I do think we have to be honest, especially up until now, we haven't had great tests to say, yes, this is the answer. We're having more tests now, but even those are, require some nuance to interpret. One of the real challenges we face is dementia is complicated. And when we look at the brains of people with memory and thinking problems after they die, it's often not just one thing. People can have Alzheimer's disease changes and old strokes, or Lewy body dementia changes in the brain and Alzheimer's disease changes in the brain. And so it's actually a little bit different from other diseases. As we get older, more stuff happens in our brain. And so there isn't always a simple answer. It can be one or two or three or more things going on.
Right. And I think that that's probably the hardest thing for people, I've said, if you walk into a doctor's office and have a 15-minute visit and they tell you you have dementia, you probably need to get a different provider because that is not how this works. So if it takes a year or two to get to a diagnosis, then that means that somebody has actually been thoughtful to try to make sure that you get a correct diagnosis. And on the podcast, I've had my little care pair, Dangle and Dot, and she was diagnosed with dementia. And then 4 years later, they changed it to mild cognitive impairment. And she's now 13 years out. So it is worth, when you get the news to make sure that you have a provider who's really done a thorough job. So now we can just kind of move into the after, like once you get a diagnosis, what do you think the key things are that the person and their family should kind of leave the office with?
Yeah, it's always good to leave the office with a paper kind of summarizing what you were told, because the research shows that when people receive this diagnosis, and by people here, I mean the person with memory and thinking changes and the caregiver, they don't remember everything from that office visit. And the things they do remember aren't always quite right. And that goes for both people, and that's just normal, right? Like if we get traumatic news, especially if it's unexpected, we're not going to take in everything that was said afterwards.
Right.
And so it's good to get a summary of the key points of the discussion, what tests were done, what was the end diagnosis, what are the next steps, so that you have something to take with you with the key points from the conversation that you can reference later.
Right.
You also want some kind of follow-up visit, though that can be tricky in specialty centers because there's just such a long wait for appointments. But also know, well, how do you get in touch with your doctor if you have a follow-up question later, whether that's through a patient portal or a phone number? Then it's good to leave with some advice on, well, what can I do now? And by that, I don't necessarily mean medications. So there's a lot of research that exercise is really good for the brain, including for people with memory and thinking problems. So that could be a practical strategy. Are there any diet changes I should make? Who can I connect with for more information, whether that's the Alzheimer's Association or the LBDA or someone else? Sometimes it can be helpful. Is there someone in my area that can give me more support? So, a Center on Aging or county help for older adults or caregivers. Is there caregiver training? So thinking through some of that practical day-to-day stuff, in addition to thinking through, is there a medication that might help me? And what would be the pros and cons of using that medication?
Mm-hmm. Yeah, I mean, I think the biggest thing is like after you've gotten a diagnosis to just become a student of, you know, maybe what the path forward may look like. But it's also important, I think, when people get this news, they're like, well, I've been diagnosed and tomorrow I'm going to be bedridden in the nursing home.
Yeah.
Like it doesn't happen that way unless you have like a major stroke. But, to realize that there's a lot of life
Yes.
left to live and that there's no way anybody can predict how fast or how slow. Like my grandmother was diagnosed with early Alzheimer's and for 15, 20 years, that's kind of where she stayed, until maybe like a month or two before she passed away, and even then she still always recognized us. But I think that's another hard part is the anticipatory planning, understanding grief, and how that plays into it. So you mentioned some resources. Are there any other kind of critical resources that families should should seek out?
Yeah, I want to, before I even touch on that, I want to touch on something you said about grief. And I think grief is really important to think about in the context of these diagnoses. And I think it's also important to say that grief isn't something that you do and then you're done with it in these diseases. These diseases have a lot of changes over time. And so there's going to be cycles of grief, for the person living with memory and thinking problems and the family and caregivers, because you're going to grieve the diagnosis and what that means for your retirement or your future. But, maybe you're really early and there's still a lot of stuff that you're doing well. You have mild cognitive impairment and you're still driving. But then at some point that's going to change. And then you're going to grieve having to give up that part of your independence. So there are going to be different things, and they could be different for the person living with memory and thinking problems and the caregiver, but you're going to grieve at different steps along the way. And that's normal. And that's good. I mean, that's part of processing it. And so I think we don't always talk about that. We talk about grief when someone dies, but there's also grief with the diagnosis and the different changes that go along with it. In terms of resources, I think, we talked about some of the big ones. You do want to get connected to an advocacy organization that aligns with your diagnosis. They can really provide a lot of support. So many advocacy organizations have support groups. They also have ways to get you connected to research opportunities. They may have resources to help you get connected to a specialty clinic if there's one in your area. They have education. They keep people updated on, new developments. And then, so there's just so much value in getting tied into an advocacy organization connected to your specific disease or that takes care of dementia more broadly. And then you really do want to know what resources are available at your clinic or in your area. So some clinics have a social worker. Social workers are a great resource in a variety of different ways. They can help okay, is there a home care agency in my area? What would that cost to me? How do I think about advanced care planning or palliative care? So social workers are a great resource if the clinic has them. And then there are sometimes county or state resources. Some counties or local organizations will have caregiver training, which can be really helpful. So knowing what is available to you, either in terms of like a national organization or something right where you live.
Right. And I think the biggest thing is that, I talk a lot about, building a care team and building your social network because I think oftentimes people like either self-isolate or the current friend group can't deal with the diagnosis. It's not like dementia is contagious. Uh, yeah, but, to really the social support and,
Yeah,
and not trying to do this all by yourself is
so
really
important.
important.
Yeah, that is so important. So, care team, I love that phrase because no one doctor is going to be enough. It really is a care team. And then I totally agree with you. Thinking about what, what are my social resources? Can my neighbors help me? Can my church help me? Can my friend group help me? Who are the people around me who can give some support? And, for some people, it's going to be I have local kids or local grandkids who can provide some support. And ideally, it would be a group, not relying on one single person, but having different people who could step in if you need help. And then, that social engagement is really important. And you're going to find, to the point you made, that some people aren't really going to be able to handle it and may disengage. But there are a lot of people out there who are great, who roll with it when someone forgets, who can deal with that. Maybe you get together in smaller groups, 2 couples rather than 8 couples. So there's not quite so much chaos going on. It might be a little easier for the person with memory and thinking problems to be in a smaller group, making sure it's a quiet environment so you're not also battling a noisy restaurant. But you want to keep those social activities and keep those connections.
Yeah, for both people.
Exactly.
That's really, the most important thing is that social engagement is so important for our brains. I've had so many people that would come into the nursing home and their families would be like, well, she has just blossomed since she's been here. And they're like, she's doing so great. We want to send her home. We want her to go home. And it's like, well, let's talk about what home looks like. Was she there by herself 24/7 all the time? And they're like, yeah. And it's like, we might want to think about how can we, I mean, it's fine if she goes home, but how do we keep the social piece that you're seeing make the difference in her overall, well-being? We need to make sure that that transfers when she goes back home because social isolation is terrible for our brains.
Yeah. And there are lots of ways now you can try to accomplish that. There are adult day programs where you go and spend the day and they have different activities, or you can have people come into the house or both. So I think being creative about how we have those social engagements can be important.
Yeah. All right. Well, I really appreciate this conversation with you today. I have thoroughly enjoyed it. Any last words before we go?
No, I think I would say, if you notice something changing in you, or if you have a loved one in your life where you think, the memory and thinking isn't quite the same, I would encourage you to get checked out yourself or have your loved one checked out. There is more and more that we can do for people living with memory and thinking problems, not only to get people a better answer, but also getting people connected to currently available treatments or helping find new treatments. And so, we don't have a cure yet, but really getting a diagnosis is the first step to understanding why is this happening to me, what's going to happen next, and what are my options are. And so I think finding a medical team that can help you is a really important thing.
Yeah. All right. Well, thank you so much.
Thank you.
Thank you so much for joining me today. Hit the subscribe button and turn on your notifications so that you're alerted when the next episode comes out, which is generally on Tuesdays around 11 a.m. Eastern Time. And again, just a reminder, if you'd like to be part of my community and learn more about aging, age-friendly initiatives, and Alzheimer's disease, don't forget to drop by my website at MelissaBPhD.com to grab your free podcast insider guide. And again, this guide contains 2 essential checklists. One is to help you age well, and the other one is to help you recognize early warning signs of someone having a memory problem. And until next time, be well.